Okay, great. They're closing the doors here. So I'll give a little introduction to myself. Welcome to today's talk, addressing behavioral health gaps for California's older adults. My name is Gerson Galdames. I'm a program officer at Archstone Foundation, and we're joined by a fantastic panel of some great leaders in the aging field. We're joined by Annie Chung, the president and CEO of Self-Help for the Elderly in the San Francisco Bay Area, Sarah Steenhausen, who is the deputy director of the Division of Policy, Research and Equity at the California Department of Aging, and Dr. Luke Bergman, who is the Behavioral Health Services Director for the County of San Diego, and I'll invite them to share a little bit about their background and motivations as well. But before we get there, I just wanted to take a little poll here of our audience to just ask who is working in the aging field currently with a service population of older adults. Could you just raise your hands? So actually not too many. I think maybe like 20%. And who here has a general working knowledge of the field of aging through work or school? Okay, yeah, so a little more. So I think we have a good amount of folks here who have experience, but also folks who are pretty new to this world. So I would say this is a really interesting talk to have at a conference that's not aging specific. Especially given that the theme of the conference is really on health equity. I always like to say that the latest ages in the human lifespan are really where the health inequity rubber meets the road. You've gone through a lifetime of health inequity and inequality, and now you have chronic conditions, you have this need for really high care coordination, and all of those gaps are just glaring in a way they haven't been seen in your lifetime. So in addition, we're kind of in a niche of a niche here. We're talking about the older adult population, and we're also talking about behavioral health. And I think behavioral health also gives us a really interesting window into sort of the multifaceted nature of health inequity. Because we start talking about behavioral health, as you're gonna see from our wonderful panel, we're talking about all sorts of things: homelessness, technology, health and social service integration. So I think you're in the right place, and it's going to be a great panel. So I will start us off with an invitation from our panel to give us a sense of who you are. How did you get into this work? What does behavioral health mean to you? And bring us to the journey of today, where we're faced with this really interesting federal shift. Set the context for us a little bit there, and then we'll dive into some of the meatier content. So we'll start here with Annie, please.
Okay, thank you, Dr. Gerson. Good afternoon, everyone. Or good morning. Good morning, everyone. So I'm Annie Chung with a community-based organization started in San Francisco in 1966. So this is a Self-Help for the Elderly. And in 2 years, we should be celebrating our 60th anniversary. We really started as part of the war on poverty. And in those days, the API seniors couldn't get access to a lot of services. And Self-Help was started to kind of respond. Mental health is one of them. But at that time, Chinatown, San Francisco has the highest suicidal rate among seniors, and also the highest TB rate. So our group was started to really make sure that the most vulnerable population in San Francisco, which are the low-income, non-English speaking seniors, get the services that they need. So over the past 50 plus years, we've kind of assembled a pretty comprehensive range of social health, affordable housing, employment training, quite a bit of services, and we provide service to about 50,000 seniors a year. We're in 5 Bay Area counties. But Dr. Gerson, you mentioned mental health. So I've been with the agency for about 40 plus years, and mental health is that big gap that we've never been really able to fill. Like when we see services that the seniors need, we try to put together programs for them. But of course, you needed funding and you needed resources, and then you needed the labor and the manpower to do it. But mental health is such a specialized area that we find it very difficult if the federal, state, and local government doesn't give support to integrate mental health with physical health and social health. So I'll say that what leads me, to my job and why is Help for the Elderly so eager to address this gap in mental health, because if anything else, the COVID pandemic, brought up to the surface the lack of mental health support for the non-English or very limited English speakers who are also very low income. So I kind of stop there.
Thank you.
And then talk about this more later.
Definitely, and you bring a really interesting, community level perspective that we'll be really interested to hear some stories too. Sarah.
Yeah, well, first, thank you so much, Harrison, and thank you to ITUP for the opportunity to talk about such an important issue today. I've been fortunate to work in the field of aging for almost 25 years, and I working in the legislature and then in a philanthropy for a number of years, and now recently having come to the state a few years ago to help implement California's master plan for aging. But really what sticks with me most and what really drives me are the personal stories, and just something that I think illustrated to me the tremendous need for older adult behavioral health services and support was a friend of mine, a family friend. I'll call her Karen, and she's in her mid-60s, and she had, suffered for many years from isolation and loneliness, and she then moved in with her parents into a mobile home park. And her parents passed away, and they assured her that she would be able to stay in their mobile home after they passed away. Unfortunately, what happened is there were some sibling issues, and her sister, who was executor of the estate, essentially said, "No, sorry, we're selling the mobile home, and we'll give you a little of the money from the sale, but it's our prerogative." The two other siblings decided that was their choice. She then had a very limited amount of resources to live on and nowhere to go, nowhere to live. And she found housing, but it was temporary because she soon exhausted all of her resources. Meanwhile, she had significant unmet needs for behavioral health. She had high anxiety, depression. She felt she didn't feel like she really had her own sense of agency to get help, and she didn't know where to go. Long story short, what ended up happening is she was so concerned and so worried about her situation, she attempted suicide not once, but twice. Unfortunately, that should have been a place where she got wraparound services that she needed. It's not just housing that she needed, but she also needed behavioral health support. She was enrolled in a Medi-Cal managed care plan, including one that offers, of course, enhanced care management and community supports. She never got connected to it. She got discharged to a nursing home, and then she got put into a small bed boarding care home where she got bed bugs, and then was left the boarding care home and essentially didn't know where to go. She didn't know what to do, and if it weren't for a friend of hers, she wouldn't have had a place to live. And she lived with this friend, and the friend soon said, "You can't stay." The landlord was saying, this is a single occupancy room. She called the continuum of care. She wasn't connected to anything or anybody. She kept getting bounced around the system. And the only resource that helped her was her local church that pooled resources and essentially started a fund and paid for her housing for a few months, but that was not enough. Finally, she got some information at the local level through the Independent Living Center that told her her rights and helped her understand what she could do. She still to this day doesn't have the behavioral health supports that she needs. She's been bounced around, and there's not really a solution, but she at least is not homeless at this moment. So to me, that illustrated so well where we are falling short as a society and how we need to do a lot more. There is an epidemic of older adult loneliness and isolation, and it drives a lot of other issues. And I think Karen's story illustrates the intersection of housing and homelessness. And I'm really hopeful that we have opportunities with the implementation of the Behavioral Health Services Act to do a lot more. And I look forward to talking about it.
Thank you, Sarah. That was a fantastic story. I think illustrates sort of the rest of the talk, and we'll get into a lot of those elements that you touched on there, Luke.
Thank you so much. I'm Luke Bergman. I'm the Behavioral Health Services Director in San Diego County, as was noted. So I'm the panelist who does not specialize in aging. Though I do come from a family of gerontologists, which is that's weird, right?
You're the black sheep.
Probably, yeah. Oh, it's not weird. It's not weird. It's totally normal. Most of my work and most of what preoccupies me are like big questions about the structure of the systems that we have to support behavioral health. Disciplinarily, I am a cultural anthropologist, urban medical anthropologist, and also a social worker. That makes me even weirder, probably, than coming from a family of gerontologists. And so, a lot of what kind of drives me in doing the work that I do is understanding that that the categories, the constructs that really define the healthcare generally, but very much with a lot of fluidity and in very kind of specifically culturally situated ways, behavioral health specifically, right? That we have an opportunity to make changes by making it a culture change project. I mean, in fact, the only way to make significant change, certainly in the realm of healthcare that I occupy, but I would actually say healthcare generally, is to think about it as culture change. And I guess I would say that again, the opportunities there are really ripe, right? I mean, the people I'm sure have heard this, right? The Diagnostic Bible in Behavioral Health, the DSM, now 5, is really just a list of cultural constructs, right? There is no real disease modeling in any of it. It's all sort of based on very specifically situated kind of syndromic descriptions that are totally subjective. And so when you kind of ask the field of psychiatry generally and kind of behavioral health even more generally to really sort of think about that, kind of two things I think simultaneously happen. One, like a sense of existential crisis, and also I think a sense of opening opportunity. So I will want us to, I think, keep that in mind throughout this conversation, that this is a field rooted in cultural construct, and cultural constructs are things that we can make hay of. They are things that we can work to change to our advantage. And in fact, again, the only way that I think we can remediate the incredibly long-standing deprivation of investment in behavioral health and sort of situation of behavioral health in the broader healthcare landscape is to think about it as a culture change project. That's kind of like my, higher than high level, so my stratus cloud kind of orientation to this work. I would say that my interest in, its significance for and the significance of the aging community in behavioral is very much informed by personal experience, stories that are very resonant with the ones that were already told. My dad died 3 years ago at age of 90. He was a very esteemed professor of philosophy at the University of Michigan, a continental philosopher, so a specialist in existentialism. So another window into why I'm so screwed up, probably. And as he got older, he developed spinal stenosis, wasn't able to really sort of care for himself. His health degraded, really, with kind of exponential rapidity because he wasn't moving, kind of all the things. He was again, very esteemed full professor on a pension, but that's not enough. That's nothing like enough. kind of pull resources to care for a person in that situation whose family is all scattered about. So, and I think the statute of limitations would probably keep me from being, kind of punished for this, but we had to deliberately destitute him, which is probably not an uncommon story. We had to very strategically dispossess him of his assets in order to get him enrolled in the PACE program. And that was the only way we could do it. That was the only option. And it's a little bit ridiculous to bemoan that, when one is in a very privileged position, when they have a choice to dispossess one's relative of all their resources. But it also reflects, Rob Bonta noted that he is trying not to use expletives. I am in the same phase of public speaking.
Thank you.
But one is inspired to use one, right? When that's the system that we have right now.
Thank you very much. I think, the stories are flowing out when you talk about this issue. It's just like these really, really terrible situations for folks. And, it's something that we don't talk about. It's not in the public's mind eye. It's not in the mind eye of a lot of health professionals because you think, you get older, it's kind of normal to be depressed, but that's not the case. It's just really not. And it's normal to have, the issues that were described here, and it's just not. So I'll also share just a little bit of my background. I grew up in Compton, California, with a lot of aging relatives in my home. I'm the son of a hospice nurse, and my grandmother who raised me was also a nurse, and I watched my family also go through severe depression just across the older adults that I was living with, and it was absolutely no resources, no discussion, zero support. So I think there's a spectrum of sort of severity and a spectrum of situations that relate to this broad term of behavioral health, and so that makes it all the more complicated to sort of address and interweave as part of the culture, as you talked about. So. And so I think, let's just open a door here, and we're going to, as soon as we walk through, we're going to, it's going to expand, and we're going to talk about a lot of different things. But one of the themes that we've talked about is loneliness. It's increasingly recognized as a public health issue for older adults. How does chronic loneliness affect mental health, and what can be done to address this concern? If we could start with Annie.
Thank you, Dr. Gerson. I think we all feel lonely sometimes, don't we? I'm sure we do. But when you don't have anybody to call, I'm talking back to 4 or 5 years, at the peak of the pandemic, small things like, where's the next meal coming from? I can't go out to get groceries. And one of the saddest things is when my senior came to us and say, the saddest thing for her is her grandchild was born during the pandemic, and for 2 years she couldn't see her and hold her, just hold the baby. And there's that kind of emptiness, that you turn around and your children are too busy, maybe with their children. Everybody is busy doing something during the pandemic, getting well, getting healthy, but the seniors are stuck. So for the older adults, we see a behavior change. We're talking about behavioral health, and why is loneliness, depression, isolation, all of them come together, and then they couldn't go see their doctors on top of it. People talk about telehealth, but telehealth doesn't work that well. Not even with us who speak English, but with seniors who don't speak, English, or their doctors might not speak Chinese, and it's hard to tell the doctor about what's bothering you, what's most affecting you through a teleprompter or through a laptop that they don't know how to operate. So all this make seniors become sometimes, for us, when we reopen our senior centers, and we run 15 senior centers across the Bay Area, we really see evidence of behavior change. Some seniors get very, very aggressive. But before, they're okay, very gentle, usually get along with everybody in the center. But now when another senior kind of jump the line or go in front of them, then they slashed out and got really, really upset. We say, where did this temper come from? So I think it's all cooped up inside here. So how do we deal with it is we make sure that we are there for the seniors when they need us, whether through a telephone call or coming back to the center, or even when they were just picking up the meals to go, when our centers couldn't reopen till early 2024, then we'll make sure that whatever they need. I was sharing with Dr. Gerson and Sarah earlier that when the senior, all she needs is to fix her WeChat, because during the time, all she can do is to use WeChat to communicate with her family, both in China and here. But when that broke down, she broke down crying, and then ended up when our IT person went to fix it, then she got very happy again. So little things like that became real big and serious, but if nobody attend to that need or help them to, do something or find a solution, then it's like stacking up, and then they kind of blow up. So mental health is very, very important to just physical health, and also even in senior centers when we don't have the mental health clinicians to address behavior issues, then our social workers have to step in and provide the voice, and they're not trained. With serious mental illness, they're really not trained to handle it. So we're looking, to Department of Aging, we're looking to federal funding, and we've been going back to SEMSA to see how community-based organizations that do a lot of socialization, social services, even with healthcare provider like us, is still not fully integrated. We try, but mental health clinicians is actually very expensive. And we don't have the budget to hire a psychologist or a psychiatrist to be on our staff. So we have to look for partners in the community to maybe help fill that gap. But it's been very challenging.
Thank you. And we'll go to Sarah, and I also encourage any reactions to each other and responding. Yeah.
Sure. Well, something I want to highlight is this issue of the need for increased attention on older adult behavioral health really came to light when we launched the Master Plan for Aging. And the first iteration of the Master Plan was released in January 2021. And it pretty much was silent on this issue. And thankfully, we have a very robust, stakeholder engagement process, and we heard loud and clear from some of the stakeholders, like, this is a huge need that not enough attention is being brought to. And so we realized that we needed to do more, we needed to do better. And so we held a series of 4 listening sessions across the state in Southern California, Northern California, Central California. And several themes emerged that I think illustrate, the problem of facing older adult behavioral health and why this epidemic of loneliness and isolation really is driving so much need. So we heard a lot about, from the local communities about the changing family systems, and it's leaving a lot of older adults alone and isolated in their communities. But then on top of that, we have a very fragmented service delivery system. So you don't have, you have the siloization of care, and you don't have the providers talking to each other and recognizing the need. But third, really, I think one of the biggest factors driving the problem, and we heard a lot about this, was stigma. And this gets into, whether it's internalized stigma of people feeling like ashamed to even seek help, but also not even recognizing that they can get help, that they could, that there are resources available to them. But there's also a lot of public stigma associated with behavioral health. And particularly for older adults, some of it's generational, but also there's a lot of cultural and very important to recognize that different populations regard behavioral health services differently. And so when you intersect race, ethnicity, age, and cultural attitude, you can really see where a lot of people don't seek the help that they might need. And there's also, I think, something that we have to just really put front and center, and that's ageism. We heard in the sessions that, some people have an attitude of, well, Hair-san mentioned this, they're old. Of course they're depressed, right? That's our societal perspective of aging, and that narrative drives so much of the discussion, and I think it's reflected in how we spend public resources. We have significant opportunities with the Behavioral Health Services Act to invest in this population, but it's not going to just happen automatically. It's incumbent on all of us to be at the table at the local level, to be part of that change, to ensure that older adult services are funded through county behavioral health and the Proposition 1. And then also we just need to do more to build more resilient communities. We heard a lot from people that, they don't necessarily want to go and make an appointment with a therapist. They might just need, one example we heard of is, there's an organization called Choice in Aging in Contra Costa County, and it's a wonderful program. It's got adult day health care, community-based adult services. It has a multi-purpose senior services program. It has a number of different, it has intergenerational programming. But one of the best things that they have done is created a knitting circle for the Afghan older women, because that's the way that they come together and do community. These women had been very isolated in their homes during COVID, and it was through that knitting circle that they were able to build a sense of community, and they talked a lot about the issues they were confronting. It was a form of behavioral health, and that's a very community-focused approach. And so we can't have some sort of one-size-fits-all. We really need to count on what we heard so much. It's those community-based organizations. It's the self-help for the elderly in San Francisco, where people go. That's their community, and we need to lean into community, build off of it as a way to address the need for addressing isolation and loneliness.
Thank you.
Building on what was just said, so one of my kind of preoccupations with the problematic culture of behavioral health care right now is its obsession with crisis, which, if you've ever heard me talk before, you probably heard me speak to this, that crisis is this notion that is like ubiquitous in conversations about behavioral health, but as something that is core to healthcare, it's unique to behavioral health, right? We don't talk about crises outside of behavioral health and the rest of healthcare the way we do in behavioral health. It's this very morally laden terminology that is affixed to behavioral health specifically, and that really sort of drives policy, which then perpetuates a preoccupation with crisis, which then leads us to never build out a continuum that actually cares for people over time, and that involves the resources that we need to address things like loneliness, but also just like disease chronicity generally, which we all acknowledge. Behavioral health conditions are chronic conditions, and people who are older suffer disproportionately comorbid physical health, chronic illness, and behavioral health, also chronic illnesses, right? So we're sort of stuck in what I think is a culturally driven loop of being obsessed with crisis and failing to pay attention to the longer arc that's necessary to actually get people well. I mean, and you see things, right? Like, have people heard of Senate Bill 43? Which is the rewriting of conservatorship law. Have people heard of the CARE Act program? Right, so these things, so more people have heard of the CARE Act program than of SB 43, I'm gathering, which is a little bit weird because CARE Act program's teeny-weeny, but SB 43 is massive. And so that is a thing that deserves more attention generally. But I would say both are kind of like driven by a preoccupation with crisis. And the fact that anything that we think about doing in the world of behavioral health has to be sort of driven by responsive to moments of crisis. And frankly, a whole lot of that is driven by the political urgency of putting people somewhere, of putting people who are inconvenient to us, whom we don't want to see as a part of our public landscape, getting them the hell out of our field of vision. And so what does that mean we have to invest in? Well, detox, right? Places like detox or or crisis response to behavioral health. Super important that we have those things, but they don't do any good if we don't build longer-term care capacity. And so, the thing that in San Diego County we are emphasizing more than anything through combinations of licensure and regulations available through CCL, like residential care for the elderly, for example, in combination with adult residential facilities and recuperative care. What we're aiming to build is a capacity for long-term residential care. And this is sort of like, this is the problem, I would say. This is like the central problem in public insurance-driven care for the aging population generally, that money does not support residential care in ways that it really needs to. It's like this massive, unconscionable gap, frankly, in the continuum of care and in the mechanisms that we use to pay for. The New York Times did, this was before the end times had befallen us, but they did a sort of kind of a series on the continuum of care for the elderly, and really focused on this in particular, I think, very effectively. So this is a parallel problem in behavioral health, I would say, driven by different things. But we don't have sufficient long-term residential care in behavioral health generally. We don't have sufficient long-term residential care for the elderly. And so at the nexus, we face a particularly acute crisis just around scale and capacity. I'm just going to throw out a couple of numbers because they're compelling. We have in San Diego County 31,000 beds that sort of fit within the broadest arc of what we could think of as long-term care, assisted living, ARFs, RCFEs, all of that. 31,000 beds. Do you know how many are occupied by people who are served through the behavioral health specialty care system that I run? No, 255 people of 31,000. And that's mostly reflecting simple economic drivers that determine access to care. I mean, the average monthly cost at this point for a board-and-care bed, where quality continues to be a huge issue, as was noted earlier. The average price is, $7,000, $8,000 a month. Mm-hmm. Most people in Medi-Cal have their SSI money at their disposal for this, and then we've got wonderful grants like BHBH. San Diego County received $44 million through the Behavioral Health Bridge Housing Grant to help subsidize the necessary patch to make people who are generally older, generally have less resources, competitive, because it's all about competing for space in residential care, right? So we are blowing our patches way up, and we are wildly behind the eight ball. And so, thankfully, state of California has written a waiver called BH Connect. People know about BH Connect. This is more like homework if you don't. It's maybe more significant than Prop 1, I would say, overall and overarchingly, because it changes the public insurance system. Prop 1 is not about the public insurance system mostly. It's about a marginal tax revenue, which, just to say, oh my God, the resplendency of riches that we have at our disposal for behavioral health, it shouldn't sit in a marginal tax revenue. It should be woven into the public insurance system, because behavioral health is health, right? Which we say with great facility, but which we don't build policy-driven structures to actually support. So anyways, BH Connect does drive some funding into the public insurance system to begin to support longer-term residential care, but only for 6 months. Mm-hmm. And there is this problem, I think, in policymakers' minds, that they stubbornly think about places like board and care as transitional housing. And I wouldn't encourage us to call it terminal housing, but this is where people make their lives. And speaking of loneliness and community, right? We need to sort of cultivate places like board and care campuses with a sense that we are facilitating the expression of agency over time for people. We are not working on people, we're giving them spaces to build their own lives. And that is also a massive, that's some cultural reprogramming that we have to do, and as quickly as possible, and with as much sort of tactical urgency, we got to get it into the payment practices that drive our work. Sorry for being so long-winded.
No, thank you. And running out of time, so I think we'll we'll go into this sort of next phase, just like a last parting remark for folks in the audience, and I'll give folks a chance to ask questions as well. But what is sort of the one approach or systems change that you would like to see in terms of integrating behavioral health into the larger health landscape, incorporating the role of the social support network, incorporating the role of technology? What do we need to leave us with something to chew on?
I think for me, self-help for the elderly was started not waiting for any government bodies to come into our community and then help us start a senior center or a meals program, or a social service program. So really, a lot of us started based on the principles, or at least the value of self-determination. So I think that moving forward, because the federal administration definitely will be much, much more hostile to us and to the population that we represent, and there's not going to be a whole lot of money or maybe care or concern, right, for the low-income, maybe limited English-speaking immigrant seniors. So we got to go back to why we got started back in 1966 and say if mental health and behavioral health is part of the comprehensive range of services that we need to provide, or else these gaps are going to, just like Dr. Berman say, they're going to be placed into a board and care home. But in San Francisco, we lost 80% of the affordable board and care beds. And now it's like $7,000 to $15,000 a month if you needed a board and care home. So it's totally unaffordable. And the system doesn't allow us to keep the seniors where they are when they needed some mental health services. So I hope that for us, we'll continue to look at how we could integrate, even as preliminary kind of services that we need, basic mental health service. But we won't call it mental health service because in Chinese, if a person has mental illness, they're translated into being stupid and silly. So nobody would ever admit that they have a depression or they feel sad or they couldn't eat. So we have to culturally adapt our services, just like Sarah said, that it had to be kind of part of our cultural fabric in order to continue to see how we could bring in clinicians who are willing, to charge a little bit less than if they're in private practice, to work for the community mental health clinics and social services, to kind of come and talk to our seniors in common language, and not saying they have to take, because no one will take medication, as a matter of fact, even if they have depression or they have suicidal thoughts, because they felt that they don't want to be labeled to be a mental health patient. So I think that we have to put all those together and make sure that we, like earlier this morning's speaker said, continue to advocate for health access, continue to advocate for language access, so that the tier 1 departments all have language access availability for the clients that don't speak English. And then continue in our own small ways and big ways to make sure that the seniors that we serve, if they needed counseling, that we find some partners in the community to give that to them. Yeah.
Thank you. Sarah?
Yeah, so I would say the one thing, this sounds very simplistic, but I think there's a number of ways to get there, is we need to focus on building resilient communities that are inclusive of older adults. And what that really means is ensuring that there are the resources and the social support that people need to be able to respond to crisis and tragedy. I mean, anytime you live, we're not going to be able to erase hardship from people's lives, but what we can do is make sure that they are connected and part of the community, and then that helps them to be able to have the agency and the tools they need, whether it be through evidence-informed programs or other community-based resources. But I think to get to where we have more resilient communities, it's really a whole of government and whole of society approach. We have to recognize, as has been discussed today, that we have a financing problem facing our system. That is how people access services as they age across long-term care system and the healthcare system. We have to address that. We have to fix how people navigate services. It's much too fragmented. We're trying to move towards a more kind of coordinated, no wrong door system, and we have the plans in place to do that. And then if you're navigating and you have a more coordinated system to address the needs of somebody like Karen, who I talked about earlier, to make sure that she has seamless access to services, you then have to make sure that you actually have the services in place to serve somebody. So we have to build out our infrastructure so that no matter where you live, no matter what language you speak, you can access the services you need. And then finally, we really need to address the workforce issues. That's not something we really touched on in this conversation, but there's a tremendous need for training, and there's a tremendous need to bring more people into the field of aging. And again, that gets to kind of this broader issue of society and our negative perceptions of aging that we can change by building resilient communities. So thank you.
Thank you.
Super quick. I think we need a full carve-in of behavioral health. I'm focusing on government and money here, shockingly. I think we need a full carve-in of behavioral health into the Medi-Cal program, and I think that we need housing to be paid for over the long haul through capitated premiums. Smattering of applause. I'm describing the extinction of my job, by the way.
Thank you. Thank you. And could we just give a hand to our panel before we go to questions? Thank you. This was fantastic. I was telling colleagues, I don't know how we're going to get through all the content that this requires, but we managed to get through a lot of it. So thank you so much for being here. And I think we have maybe just a few minutes for burning questions from folks. I see a hand right up here in the front. And thanks for the ITUP crew helping us get a mic around. We'll go right here in the front in the blue. Oh, yeah.
Hey, I'm Selene. I'm the research director of Ethnic Media Services. Annie and Sarah are familiar faces. In the previous panel, they talked about this TRO that just got passed, extending a lawsuit that blocked the federal funding freeze. I read it, and it only said it lasted as long as the next court hearing, which is supposed to be scheduled shortly. I'm wondering, from government and CBO health, what are your colleagues saying? Do you have a contingency plan? How worried are you?
How worried am I? I'm substantially worried. California, and I think there's been a lot of people noting this, like, we should all be, those of us who don't live in California or work in California, but who are at this conference, I'm so sorry, potentially. Californians are fortunate to have political actors in this state and administrative leaders in the state who have committed to firewalling California as much as possible. But yeah, like a big part of the budget that I run, like my budget in San Diego County is about $1.2 billion. Big part of that is block grant funding. And so, poof, it's worrisome.
Sarah, we're very, very worried. San Francisco is facing like a $876 million deficit. So already our aging programs, all the departments were asked to do a minimum of 15% cut. And to cut that means that our services will be cut. But if more cuts are coming down from federal government, it will be a major issue with us. The first executive order was like eliminating the birthright, citizenship birthright of people born in the United States. Almost immediately, our community, the Chinese newspapers and the radios and the televisions said that people are calling in so worried that they might be deported or sent back, right? I mean, you don't know what can, but the fear is real. And then the next day, they said they saw the ICE coming into some Chinatown employers asking for IDs. So of course, immediately our nonprofit legal services make sure that we all know our rights, and we tell our clients that they also have rights not to show their ID or answer any questions. I think that for us, Sarah, if if the pauses that they are bringing down, saying that they're now pausing some of our programs because they have to make sure that we are complying with the executive order's intent. That's very worrisome, that they could pretty much shut us down, right? If they pause long enough and not pay us for some of the programs, like meals program. Where do you get $1 million+ to provide the meals? So I think that we have to work with our local government, state government, governor's office, State Department of Aging, Sarah, to make sure that there's some rainy day funding for us if that really comes down. I was thinking of calling some foundations and see if they could, allow for, if really funding are held up for MSSP, case management, nutrition, or any of the affordable housing services that are federally funded, then we're all in trouble. Yeah, so hopefully philanthropy, government, nonprofit will find some relief for us if that happens.
So I was told I had until 12:20, so we have 4 minutes. If there's one more burning question for folks. I think right here in the front.
Hi everyone, Kieran Singh with the Department of Healthcare Services. I work in incentive programs. I'm attending today as a civilian, and I want to see and ask, how does the panel feel that the BHT Prop 1 and BH Connect look to the future in addressing a lot of the gaps that all three of you have described? And I just want to get your personal insights on that.
Yeah, I mean, I think there's so much opportunity, as has been discussed, and that it's really a responsibility of us at the state level to help build capacity of our aging network to be engaged in these conversations. We have a number of examples of evidence-based programs that are successful in meeting and addressing behavioral health needs of older adults. So if we need to figure out how they can ensure that they get, oh my goodness, sorry, my phone's ringing, that they can get connected at the local level, do the advocacy that's needed to make sure that they are part of the conversation and that older adults are not left out of the conversation.
What's your job at DHCS? Just kidding, civilian. I would say that the T that BH needs are the two things I mentioned before. We need to, right now, behavioral health services, Medi-Cal, public insurance-driven behavioral health services are so laden with perverse incentives that it's almost farcical, frankly. We are sort of pitted against managed care plans, right? County behavioral health services departments are. They have no stake in actually doing upstream work across age cohorts. So that needs to get fixed. It's not fixed by the T in BH of BHT, nor is it fixed by Prop 1. And so that's the big thing. And then I think making behavioral health a more genuine part of healthcare by pulling it under capitation. That could be subcap. Counties could run it. It doesn't need to be my job is extinct, right? Counties could run behavioral health organizations and approach it that way. But we need just more. And I have a lot of affection for Dr. Galley, but we need more courageous structural change in order to address the problems. And Prop 1, I don't feel does that. I think that there are some things that are, the bond measure is great, more resources, but excluded from eligible spend of the bond funding is long-term care that isn't clinical. Yeah. That's only funding for clinical settings. And that, again, I feel like that sort of, that perpetuates a deep failure to want to grapple with what behavioral health care is and what our behavioral health is collectively, which is not something that is adequately addressed by episodic trips to a clinic. But that we need. Thank you.
I'm so sorry to cut you off there, but last comments from Annie, if there are any. Yeah.
Yes, Sarah reminded me that we have to speak up. If Prop 1 excluded older adults in the decision-making tables, then we must be there. Yeah.
Thank you, and thank you everyone for attending, and thank you all.
Thank you. It was so nice to meet you.
Please come up to panelists with any further questions, and we're happy to discuss. Thank you.